And next speaker is Frank Bloomfield. Where are you? Hi, welcome.
Thank you. And thank you very much to the organisers for inviting me to this excellent meeting and this beautiful city. It's a real pleasure to be here. So I'd like to approach the evidence slightly from a different perspective. Rather than talking about the evidence that is there that we shouldn't be accepting, I'd like to think about some of the claims that there is evidence when in fact there isn't, and also talk a little bit about certain specific groups where, with a little bit of evidence, it may be possible that we could perhaps get some disproportionate gains for the amount of investment that we put in. So I'm going to focus my talks in the context of New Zealand because that's where I'm from, and also around early life because I'm a neonatologist, so that's obviously my bias, so I hope you'll forgive me those two things. So this pyramid shows you the childhood obesity plan of the New Zealand government released last year. It's a 22-point plan. It looks very comprehensive. It covers everything from community-based programs at the bottom. Sorry, that's not quite in focus, is it? You can see it says Healthy Families New Zealand at the bottom, Health Board nutrition guidelines. It goes up through physical activity that we've just heard there's no evidence for. It goes up through marketing and advertising food products. Yet our government has made it quite clear that it's not going to adopt the WHO recommendations on marketing. So why it's in the health plan, I'm not quite sure. Partnership with industry, and yet we're not going to adopt the sugar tax. Then we come up to increased support, and we can see here, for example, adopting the gestational weight guidelines for women who are overweight and obese. I'll come back to that shortly. And on the left, the one there next to that is around gestational diabetes guidelines. We heard yesterday that indeed gestational diabetes is a risk factor for offspring obesity. And New Zealand and Australia have recently released joint guidelines conducted with the best possible methodology, fully concordant with the AGREE methodology. It's about 240 pages long, a very impressive document. And what does it say about managing gestational diabetes for childhood obesity? Nothing, because there is no evidence. The only thing it says is that we do not know what the best threshold for diagnosing gestational diabetes is for offspring health. Once we have diagnosed gestational diabetes, we do not know just the glycemic target that we should be aiming for to improve offspring health. And yet here it is in our obesity health plan as proposed as a guideline that will improve childhood obesity, whereas it will not. At the top there, we have at the pinnacle of the triangle the cherry on the top of the New Zealand childhood obesity plan, the before school check, and target to refer 95% of obese children for nutritional and physical activity guidance. So we've just heard that there is no evidence for that. And also, if we look at the before school check, this is a health check that's supposed to pick up lots of health issues in New Zealand children. It is unvalidated. And when we recently conducted a validation of 500 New Zealand-born children aged 4, we found that the correlation was so poor as to be practically non-existent. So this suggests that our childhood obesity plan in New Zealand claims to be based on evidence, but in fact is not. We do know, of course, that if we really want to have evidence-informed practice, we need to go around this sort of evidence cycle, if you like, whereby we identify a gap in the evidence, we undertake studies to fill that gap, we then may want to understand mechanisms so that we can further target possible interventions. We may even want to undertake experimental studies, such as we heard from Claude in mice or other animals. We then need to synthesize the evidence, develop guidelines, and then crucially, we need to actually implement those guidelines into practice, which is another whole branch of science, implementation science, to make sure that the evidence we have is actually taken up into practice. So we do know, based on evidence, some of it human cohort studies, some of it randomized trials, some of it animal studies, that early life is an important time for preventing childhood obesity. And that can be demonstrated in this diagram where on the x-axis we have the life course, increasing age across the x-axis, and on the y-axis we have the burden of health-related, obesity-related disease. And you can see that as one proceeds along the life course, one's plasticity or ability to adapt to the environment decreases, and the burden of environmental influences on our health outcomes, such as obesity, increases. We can see that if we try and intervene in adulthood, there is little effect, and I think we all know that this is the case. We can understand that if we were to try and intervene in childhood, that we may have a more beneficial effect. There is a lower burden of obesity-related disease, more plasticity, and we can see from the gap between the solid blue line and the dotted red line that the health gain may be better. Equally, we can see that if we were to intervene before conception or in pregnancy or in very early life, that we may have the maximum possible benefit. So we do have evidence that intervening in early life may be the time to intervene. What we do not have is the evidence to tell us exactly how to intervene. So some of the opportunities that there may be for intervention in early life are around future mothers before pregnancy, such as women of childbearing age, and ideally I would suggest well before pregnancy, so into adolescence, and I'll come back to that shortly. It could be during pregnancy, for which there is actually limited evidence for effectiveness that I'll come back to, or in infancy, and here perhaps focusing on particular groups where a targeted intervention may be of benefit. And fortuitously, I've highlighted breastfeeding there. I would agree that the evidence for breastfeeding preventing obesity is not that strong, but we do know that it has numerous other effects. And for example, in New Zealand, that has endorsed the Baby Friendly Hospital Initiative, it has endorsed the WHO guidelines on exclusive breastfeeding for 6 months. We start off with very good exclusive breastfeeding rates, but then around about 3 months, there's a dramatic drop-off in our breastfeeding rates. What else happens around about 3 months in New Zealand? Well, statutory maternity care finishes. 14 weeks in New Zealand, 8 weeks at least of which must be after birth. And there is no obligation on the employer to provide any support. And we can see that then breastfeeding finishes as women have to go back to work. And although breastfeeding may not be associated with obesity, increased length of time in preschool, in infancy, is. So if we just think about pre-pregnancy and pregnancy, we know from the Southampton Women's Study, a large cohort study following 11,000 women of childbearing age through pregnancy, from before they became pregnant, that the pregnancy outcomes are related to maternal nutritional status, not just BMI, but also the actual micronutrient intake that they take. However, we also know that despite the fact that these women knew they were enrolled in a study of nutrition in pregnancy, that many of them, about a third of them, were planning to become pregnant, that their nutritional intakes were pretty poor. And this is in an affluent city in the south of England, such that a very small proportion had nutritional intakes that met all of the recommendations. And that applied even in those who were planning on becoming pregnant. And furthermore, once they did become pregnant, their diets hardly changed at all, suggesting that just informing women that they need to change their diet is unlikely to be successful. We come back to the Institute of Medicine guidelines for gestational weight gain, which were refreshed in 2009 and have been widely adopted around the world. And as you could see, they're on our pyramid also. What do these guidelines actually tell us? They tell us about the effect of moderating gestational weight gain in obese women on pregnancy outcomes. That is, the outcomes on the mother and on the baby related to birth. They tell us nothing about the long-term outcomes for offspring health. And yet they are incorporated in guidelines for preventing childhood obesity. I would suggest that this is a significant anomaly. And indeed, the animal experimentation tells us that altering plane of nutrition during pregnancy may actually increase obesity or adiposity. These are data from an experiment in sheep, where very well-nourished sheep were randomized to either a stable plane of nutrition or to a decrease in nutrition from before conception through the first part of pregnancy, of a 20% decrease. And you can see that in adulthood, the offspring actually had a 4-fold increase in adiposity. Now, you may well say these are sheep. We have a lot of them in New Zealand, and this isn't very relevant for humans. Where's the biological plausibility? Well, if we think about it, pregnancy is a state of obligatory weight gain. You have an obligatory increase in mass accounted for by the fetus, the placenta, amniotic fluid, the uterus, the maternal expansion in blood volume, which accounts for about 9 kilograms. The lower limit of the recommended guidelines by the IOM is a 7 kilogram increase for women who are obese. That means that if a woman only gains 7 kilograms, she is losing 2 kilograms of mass. What's she likely to be losing? Adipose tissue. Where does that go? Free fatty acids, crosses the placenta down the concentration gradient, and you could have a good biological argument as to why, in fact, the offspring may become more obese. Now, I'm not saying that's the case because we do not have the evidence, but it is evidence that we could get relatively easily. Another example for pregnancy would be exercise in pregnancy. The benefit or otherwise of exercise in pregnancy is conflicting. Again, if we look at a couple of small studies in New Zealand, the first study found a positive benefit on birth weight, a reduction of 10%. But when you look at that study, it is almost exclusively Europeans who actually had a normal BMI to start with. When the study was repeated in South Auckland, where we have an obese pregnant mother rate of about 60%, and almost all of them were Pacific Islanders, there was in fact a slight increase in birth weight and adiposity of the offspring. So this brings us back to the fact that maybe we need to intervene much earlier, and the importance of behavior change in adolescence. And indeed, this was highlighted in the ECHO report, as you can see there, and the lady on the right of that slide is a young New Zealand school student, age about 17, a single mother, who went to the WHO to talk to them about the importance of appropriate communication of information to adolescents likely to bring about behavior change. And this is something that we've been doing in New Zealand for some time through the Adolescent Healthy Start to Life project, where we're trying to communicate information to adolescents in a way that empowers them to make behavior change by embedding the science within the New Zealand curriculum. So it's not adding it onto the curriculum, it's embedding it within the curriculum. And we do have evidence that this may indeed bring about change. Here I'm showing you some survey results from before the intervention on the left, 3 months post the intervention in the middle, and 12 months post the intervention on the right. And you can see two questions there. On the left, the food a woman eats when she's pregnant affects the health of her baby. Not surprisingly, most adolescents think that's right. But nevertheless, after the intervention, the proportion does increase significantly. Much more importantly, look at the one on the right. This is about food a woman eats when she's pregnant affecting the health of her baby when the baby is grown up. You can see that to start with, only about 50% thought that that was likely to be true. By 3 months, that had increased to 80%, and at 12 months, although there's been a decrease, it's still a significant improvement, with 70% agreeing that this is likely to be the case. So we may be able to improve health literacy through these sorts of interventions, but does that result in behavior change? Well, again, we have some preliminary evidence to suggest that this is the case. Here you can see the effect on nutritional intake in these children, in these adolescents, 12 months after the intervention, with the green bars showing an improvement and the red bars showing an adverse or a negative change, and you can see that by and large the green vastly outweighs the blue. So if we just come on briefly to think about at-risk populations, and if we think about the newborn, and particularly, for example, the preterm newborn, which affects about 10% of pregnancies worldwide. We know it's about much less than that in New Zealand, but it's much higher, for example, in the US at about 11.6%, and in parts of Africa at about 15%. So preterm birth is associated with increased risk of NCDs, including obesity. Even being born only 1 to 5 weeks early doubles your risk of obesity in childhood. Now, depending on your baseline risk of obesity and your baseline risk of preterm birth, this could account for a significant proportion of the obese population. For example, in New Zealand, we've calculated that it accounts for about 14% of our obese population and about 9% of our diabetics. And if we think that by the time a baby born preterm, even 1 to 5 weeks preterm, reaches term-corrected age, it has almost double the fat mass of a term baby born at the same time, we can see that maybe there is a period, an opportunity for intervention here, but we do not know why, and we need the evidence to tell us why this might be the case. One possible reason could be related to the growth trajectory these babies have, where they initially have growth faltering, and then they have a period of accelerated growth. And we know that this accelerated growth is associated with later health outcomes. Some of these are good. For example, in lower income countries, accelerated growth in the first year of life is associated with decreased mortality from infection, obviously a good outcome. In higher income countries, we can see that for every 1 standard deviation increase in weight change from birth to 4 months, there's a 20% decrease in the risk of an IQ less than 85, another good outcome. But there's a 27% increased risk of obesity. So this suggests that there's a trade-off between cognitive and metabolic outcomes. And maybe we need to understand why that trade-off exists to be able to tackle it. One possibility is that these outcomes are different in boys and girls. Boys are more adversely affected than girls, as many of us know. And yet, how do we treat preterm babies? How do we treat children with obesity or try and prevent it? We treat everyone the same, as a big homogeneous mass, boys and girls the same. Maybe really we should be thinking of it more like this, at the beginning of precision medicine, where we need to target interventions differently for boys and girls. We know that boys and girls' metabolisms are different, that they grow differently, that they have different growth rates, and yet we do not pay any attention to this. Once again, animal studies suggest that there is good reason to think that we should. This is just supplementing newborn lambs for 2 weeks in a way very similar to the way we supplement newborn babies preterm babies who aren't growing well. You can see on the top there, incident area under the curve, 6 months later. It is completely different in the way the response is in males and females. And further down, those bottom 2 graphs show you epigenetic change, showing that it's an epigenetic mechanism that is leading to this difference. So I'll skip the unpredictable nutrition because I'm going to talk about that in the workshop later, and just come back to thinking about the way that we actually need to talk to some of our communities. These are just a couple of bits of data on how Māori, our indigenous people in New Zealand, view their own weight and their child's weight. On the top there you can see a mother assessing her own weight, and 55% of them think that they are overweight or obese, whereas the actual figure is 66%, so an underreporting, as we know, is commonly the case. But look at the bottom one, how they rate their child. They rate 11% of them as having been overweight in the first year of life, perhaps that chubbiness of the very attractive baby. But by the time they get to 3.5 years, only 2% of mothers think their child is overweight or obese. The actual figure is over 25%. A huge 10-fold discrepancy between how the mother views her child and the reality. And this may partly be due to the fact that for Māori, obesity is not seen as a health issue. Being large is good. And Māori do not think that their family are dying of obesity. They think they're dying of diabetes, and diabetes really worries them, but obesity doesn't worry them. So if we frame our conversation in terms of obesity, we're not getting the message across. So just to conclude, I think that we need to consider that many of our guidelines that claim, or many of our packages of care or interventions for obesity that claim to be based on evidence are actually not based on evidence when we look at them in detail. We need to think about the way that we communicate the information to families, that it has to be both culturally appropriate and also, perhaps most importantly, as demonstrated by the adolescent data, that is empowering for behavior change rather than just telling people what to do. And there may be target groups where it is possible that interventions may have a disproportionate effect for the benefit that for the effort that we put in, and that maybe this is an area that if we target for improved evidence, we may be able to make some headway. Thank you very much.
Thank you very much. We shall go ahead. What workshop is it that you're in?
G. Workshop G
The
on the
title?
echo zones.
Sorry?
G, is that right, Peter? Echo zones.
Echo zones,
yes.
right.
In that room there, I
Yeah,
think.
so you can hear more from Frank or ask him questions there, or also over lunch. Thank you.
Thank you.